Welcome parents, grandparents, aunts, uncles, and anybody who is involved in caring for a child. This is The Owner's Manual, a podcast for parents, and I'm your host, Drew Nash. We have another great show for you today full of interesting information relevant to parenting and raising kids in this modern world. Today, we're going to talk with an expert on food allergies, Dr. Jaspreet Dhami. Dr. Dhami is an allergy specialist who works at Latitude. Unlike most allergy offices, Latitude is an office that specializes only in diagnosing and treating people with food allergies. So how do they treat food allergies? Well, if you listen today, you will find out. We also have an interesting Pediatric Fun Facts segment today, so get ready for an hour of listening and learning. But before we dig in, of course, we have the boring disclaimer. While we hope that listeners are able to learn and benefit from the content of this show, the information discussed on the Owner's Manual is not intended to diagnose or treat any specific individual or condition. There is no substitute for direct patient care from a trained clinician. If you have concerns about your child, we recommend that you make an appointment with your child's healthcare provider for an evaluation. Now that we have that out of the way, let's get on with the show. Pediatric Fun Facts. For today's Pediatric Fun Fact, let's talk about mono. Mononucleosis is caused by a virus called the Epstein-Barr virus, or EBV. Most people are familiar with how mono presents in a teenager. They get large lymph nodes in their neck, huge tonsils, and they're extremely fatigued. Sometimes we worry about an individual's spleen getting big when they're acutely sick, and because of that, we sometimes limit their participation in contact sports like football because of the risk of rupturing the spleen. Mono in the teenager can sometimes present as a relatively short-lived, mild illness, which oftentimes doesn't even necessitate a visit to the doctor. In the classic case, however, kids come in pretty uncomfortable, particularly with their throat, and the illness can go on for several weeks. Those cases are usually fairly straightforward. Treatment involves rest, a lot of napping, limiting activity until they're better. Sometimes we give a teenager with a severe sore throat oral steroids to help shrink the swelling, which usually makes their symptoms better quickly. The concern is that while the prednisone decreases their discomfort and they feel much better, they still are fighting off the virus and should not push things too quickly despite the decreased symptoms, or they may relapse and get worse. However, mono does not always present in the classic way. In medical school, we're taught mononucleosis is the great imitator, as it can present in a variety of ways that can be quite tricky. A few times a year, I'll see a child that might be elementary school age, middle school age, or even in high school that comes in complaining that they're just tired. Of course, we have to discuss sleep and make sure that the child is getting good rest. But if the history does not suggest a sleep disorder or any other obvious problem, I'll do a laboratory workup looking for anemia, hidden infections, inflammation, and so forth. One of the tests I do is an EBV panel. Unlike the quick mono spot, which can only tell us if an individual has an acute infection, an EBV panel can tell us whether or not an individual has had mono at some time in the past, whether they have it currently, or whether they've never had it. Except for unusual cases, once an individual has recovered from mono, they won't get it ever again. A lot of times when I do this test, we'll find out that the child has had EBV or mono in the past, despite not having a history consistent with it. This is where mono can get interesting. While we discussed how mono presents classically in a teenager, it's only a small percentage of individuals who will get it at this point in their life. Most people are exposed to EBV as preschool-aged kids. Mono in a 2 or 3 year old child usually presents with minimal symptoms, or even no symptoms. Since the infection is spread primarily through saliva, we do call it the kissing disease for a reason, you can imagine that preschool-age kids are able to spread this to one another quite easily. Sometimes a preschool-age child with mono will come in for a sore throat that will be diagnosed as a viral infection, while other times their symptoms may be so mild that they may not even need to be seen by a healthcare provider at all. It's the pediatric patient that does not get mono as a toddler that's susceptible to getting it as a teenager or young adult. For reasons that are not that well understood, the immune response in an older child to the virus is much more robust, resulting in the huge tonsils, sore throat, large lymph nodes, and extreme fatigue that we associate with most EBV infections. A couple of important points about EBV infections in general. As I mentioned a minute ago, the virus is spread predominantly in saliva. Thus, you can actually get it from kissing somebody, but more often people get exposed to it by sharing food, drink, or water bottles. The incubation period for mononucleosis is generally around 8 to 10 weeks. So someone who comes in and is diagnosed with mono did not likely get it exposed to it a few days ago from a friend, but more likely a few months ago. Also, even when fully recovered, an individual who has had mono will shed the virus in their saliva for anywhere from 6 to 12 months. Because of this, it's not realistic to isolate someone with mononucleosis. Rather, I usually educate them as to how the virus is spread and have them avoid sharing food or water with others for about a year. Who they choose to kiss or not kiss is beyond my control. Interestingly, I did have a teenage boy come in to see me about 10 years ago for an EBV panel. He was not sick or otherwise ill, but he wanted to have the EBV panel done to determine if he had had mono already in the past. You see, there was a girl at school that he was very interested in. He wanted to ask her to the junior prom. She had just recovered from mono, and he was worried that if she said yes to the date and things went well, that he would get sick. I did order the test on the boy and determined that he had had mono at some point in the past. He wasn't at risk at getting it again. Let me tell you, he was very excited when I relayed the news to him. Green light, game on. If I recall correctly, he asked her to the prom and she said yes. And that's your pediatric fun fact for the day. And now a word from today's sponsor.
Are you tired of dragging your child out to urgent care when they're sick, only to have to wait in a room full of other sick people? Is it hard to find a time in your schedule that works to have your child seen? Doesn't it seem that every time you call for an urgent care appointment, you're told that there are no more appointments available? Of course you are. Well, now here's an alternative. House Call for Kids. House Call for Kids is a telehealth-based urgent care for children and young adults who are located in California. If you go to housecallforkids.com right now, you can click on the Schedule tab and see what appointments are available today, tomorrow, or any day in the next 2 weeks. All you have to do is click on the time that works for your schedule. Then you'll be asked to pay a quick deposit to hold the appointment, and then done. For your child's first visit, there are a few forms to complete online before the appointment, but that's it. Any prescriptions will be sent to your pharmacy of choice at the end of the visit. Labs and x-rays can be ordered too, if needed. Of course, there are some kinds of things that aren't appropriate for telehealth, lacerations, possible fractures, and so on. But surprisingly, most pediatric ailments can be managed through a telemedicine visit. So whether it's an acute illness with fever, a rash or pink eye, or even a behavioral or feeding question, why wait in long lines with other sick people when you can receive quality, experienced pediatric care from the comfort of your home? Housecallforkids.com. We are here when you need us.
And now, back to the show. Today, we travel to San Ramon, California, to Latitude, a group that specializes in the diagnosis and treatment of food allergies, to interview Dr. Jaspreet Dhami. Dr. Dhami is a board-certified allergist and immunologist who's experienced in providing specialized care for food allergic patients of all ages, including testing, diagnosis, and treatment with oral immunotherapy. Prior to joining Latitude, Dr. Dhami cared for adult and pediatric allergy patients in private practice at Northwest Asthma and Allergy Center in Issaquah, Washington. Following medical school, she completed her internal medicine training at Creighton University Medical Center in Omaha, Nebraska. She returned to Seattle to work as an academic hospitalist at Virginia Mason Medical Center and then completed an allergy immunology fellowship at the UCLA VA Greater Los Angeles Healthcare Program in Los Angeles. I am so excited to get to sit down and talk with Dr. Dhami today. Welcome to the Owner's Manual, and this is Jaspreet Dhami, who is an allergist, and we're at Latitude, and we're in the San Ramon office, but there's multiple offices in the Bay Area, or are you outside of the Bay Area as well?
Yes. So thank you so much for having me this afternoon. So I'm actually in the San Francisco office, and we have several clinics here in the Bay Area, San Ramon being one of them. We also have Redwood City as well as San Rafael. We have several clinics in Southern California. So
you do. You are statewide.
We are statewide.
Not just Northern California.
Yes, and we have several in Southern California now. So West Los Angeles, Studio City, Irvine, and then we're opening a new clinic in San Diego in a couple of months as well.
Great.
And then we're also in the New York area.
So you're not just in California. You are transcontinental.
We are transcontinental.
Okay. Yeah. That's great. And so you are not just an allergy office. This is food allergies in particular. Let's just talk a little bit about what Latitude does. I have a million questions about how you do what you do. And I just had a tour of the facility and talked to all the staff and everybody. But tell me a little bit about what Latitude does that's really different than going to see your average allergist who does food allergies and environmental allergies and other things too.
So I'd love to just share a little bit about my background and
Absolutely.
how I ended up at Latitude. So after my fellowship, my allergy immunology fellowship at the UCLA VA Greater Los Angeles Center, I actually practiced in private practice at Northwest Asthma and Allergy Center in Seattle.
Got it.
And practiced all types of allergy, but I'd always had a passion for food allergy. So my niece, who's now 10 years old, has severe wheat, egg, peanut, tree nut allergies. And so I was really focused on food allergy up in Seattle, but my care sort of stopped at doing skin testing, blood testing, food challenges, and I really wanted more. I wanted to be able to offer my parents options such as treatment. And so that's where I sort of learned about Latitude and met our founder, Kim Yates, and was connected with Latitude. And that's sort of what brought me to the San Francisco Bay Area. But what's special about Latitude Food Allergy Care specifically is we're the largest network of food allergy clinics in the U.S. And we focus predominantly on immediate type of food allergies. So usually when our patients come in, we start with the history. So we know the clinical history, of course, is the most important piece of the puzzle. From there, we'll do skin testing, blood testing, food challenges. We have the capability of doing more higher risk food challenges. And so we have a very high pass rate with those. And then we also, of course, offer food allergy treatment. So both oral immunotherapy as well as Xolair.
So tell me more about the oral immunotherapy. You call it OIT.
Yes.
And so what does that involve?
Oral immunotherapy, it's incredible. So at Latitude, we treat patients of all ages. We start as young as 8 months, and then we've successfully treated many adults as well. And so we have a 97% success rate for patients successfully reaching their maintenance dose for patients under the age of 4, and that's 92% for patients of all ages. We treat all the top 9 allergens as well as 40 lesser common ones. But what it involves is we basically give our patients gradually increase the allergens that they're allergic to. And we can treat several allergens at one time. And what it involves is coming into clinic every 2 weeks where we gradually increase that dose. And on average, it takes about 8 months to get to your maintenance dose or goal dose. So say if you have a peanut allergy, for example, the maintenance dose is about 1.5 peanuts. Now, we know the younger that we start oral immunotherapy, the greater success we have because we know the immune system is still malleable at that age. So I recently, for example, had a patient who finished cashew OIT a year ago, and he recently completed a food challenge to 18 cashews.
So when you finish OIT, what does that mean for an individual who finishes? What are they able to do? What have they achieved?
So the first piece is what's their goal? What is the patient's goal? What is the family's goal? Now, many kiddos, they're being fed their allergen and they have an aversion to the taste. So
because it makes them feel sick.
Yeah, exactly. And it's something that they avoided for so long. And so there's a lot of fear and anxiety, of course, about dosing every day with their allergen. And so many often just stick to that 1.5 peanut, 2 peanut M&Ms. Now, we also have many kiddos and patients who love the taste of their allergens and want to eat more. And so dependent on a patient's goals, for example, if their goal is to free eat and eat large amounts of their allergen, eat that peanut butter and jelly sandwich, eat a handful of cashews, we work with our patients and families to get them there.
So you can have a kid who has an anaphylactic reaction to peanuts, and you can, through the OIT process, get them to a point where they can eat a PBJ?
Yes.
That happens.
Yes.
Because I was under the impression it was more just to minimize how reactive they were so that it wouldn't necessarily result in them needing an EpiPen if they had an exposure. But you're saying you can actually get them to the point where they can choose to eat purposefully nuts.
If that's their goal. So the first sort of treatment achievement is getting to that maintenance dole, which we know protects against accidental exposures, cross-contamination, so that if you eat something that has, peanut in it, you hopefully have no reaction at all. And if you do have one, it's more mild. And then over time, if the goal is to eat larger amounts, we can definitely get our patients there.
And you get there by increasing their daily amount of exposure, by giving them more of that substance?
Yes.
That's how it works. So you get to a point where you're eating 18 peanuts a day. That's a PBJ.
Yeah.
Got it. And really getting them there and not having hives or feeling sick or stomach aches. That was a delicious sandwich. I'll have another one tomorrow.
And that's where that small amount of exposure, we've trained the immune system to gradually be able to tolerate larger amounts.
That's great. What's the process for testing someone and coming up with that treatment plan?
So for our typical food allergy patient, the clinical history is the most important piece. So what happened when we ate the food? What was the timing of the reaction? What did we see? Did we use antihistamines to treat? Did we need to use an EpiPen if we had an Epi prescription? And then from there, we start with a skin test or scratch test. So we usually place the skin test on our patient's back. It just involves taking a small amount of allergen, no big needle involved, it's not painful. And then we have results within 15 to 20 minutes.
And is that the grid that everyone's familiar with? They have a grid on the back with all the different things and
yes, exactly.
Test them all, and then there's a control that's like a histamine control.
Yes, so we have a positive control, which is exactly what you said, our histamine control. We have a negative control, which is our saline. So histamine control greater than 3 tells us that the skin test that we're doing is a good test.
Is valid, because if someone doesn't react to that, then they're not going to demonstrate valid response to a potential allergen.
Yes, and that means some antihistamines are lingering, so it's important to hold those.
And someone should not be allergic to saline.
Exactly.
Since it's coursing through our body. Yeah.
Yes.
Okay.
Unless they're dermatographic and have sensitive skin, then we may see it come up. So from there, for any positive skin test results, we do obtain blood work as well.
So you confirm it with that?
Yes.
Okay.
We like both sets of test results, especially if our patients are considering oral immunotherapy, just to watch the trend of the skin test and blood test results over time.
And you can quantify the skin test results by how large a reaction there is?
So it's a positive test result is 3 more than the histamine control.
Got it.
A negative control. So most often the saline is negative or 0.
Sure.
So in most cases, a positive starts at 3 millimeters.
Okay. And if it's 3 versus 5 versus 7, does that necessarily indicate you're more allergic or you have a higher reactivity, or is it just either positive or not positive?
So the size of the wheel doesn't give me information on severity of allergy.
Okay.
The reaction history, of course, does.
Sure.
So if 2 body systems are involved and we saw signs of classic anaphylaxis and Epi was given, that's a severe allergy, of course.
I want to come back to that, so let's put a pin in that.
Okay.
Keep going.
And so the most important piece is the reaction history. So the size of the wheel doesn't necessarily, whether the peanut skin test is 3 or 10, tell me, Johnny has a more severe peanut allergy because his wheel's 10.
Okay. And then, but the blood test, there are gradations of positivity.
So a positive blood test typically starts at 0.35. Now, same thing, I've had patients have anaphylaxis to peanut with positive blood testing that's not necessarily greater than 100. I would say anecdotally, when I've seen the blood testing be really high and greater than 100, quite often they have had an initial, pretty severe reaction to peanut. But even then, the severity is determined on the reaction history. And so that's why it's so important for any patient who has had a food allergic reaction, whether it only presented with hives that first time, to still carry their EpiPens with them, because we can't predict what future reactions could look like.
Right. You only know what's happened in the past. You don't know what could happen next time.
Yeah.
And one of the things I heard when we were discussing things before the interview started is when you start someone on oral immunotherapy, you can track their positive, their blood test results. and see that number decrease.
Yes.
And that correlates with the level of potential allergen.
That we're seeing a response to an intervention that we've made.
Okay.
And so especially in our younger kiddos, so when we're starting OAT under the age of 4, often when we're doing testing at that 1-year mark, so after they've been on their maintenance dose for a year, we typically see greater than a 50%, sometimes even more reduction in skin test and blood test results, which is so exciting to see as a clinician. And then the parents are just, in awe.
Yeah, that's great. What's the typical kind of scenario? I know from my perspective in an office, we have a child who may have had hives. We don't know if it's a food trigger or not. Then it happens twice, or we do blood tests and we have evidence that there's some sort of an allergen. We refer to you. You see them. You have the blood test. Usually I order the blood test before I send them to an allergist. That's usually the scenario. So you already have that. Do you have to repeat that, or is that sufficient?
It depends. I'm always like, I want to take away work from our pediatricians. So I'm like, if there's a concerning reaction, just send them to me, and then we'll start with the skin test and go from there.
And then skin test, blood test, and then not everyone gets immunotherapy. Some people, you say, yes, you have an allergy to peanuts, for example, and then you may counsel them about what to do if there's an exposure, and then other patients you may choose to initiate the immunotherapy.
I would say most patients are candidates for oral immunotherapy. So in my practice, I offer it to essentially everyone.
Everybody.
There may be some factors like uncontrolled eosinophilic esophagitis, where we want to make sure that the EOE is under control and in remission, and we're working closely with the gastroenterologist before we start OAT.
Because you don't want to make that worse.
Exactly. But I've never had a scenario where someone hasn't been a candidate for OAT or we haven't been able to try.
And what do most parents want to go that route, or do most kids or patients, or is there some kind of an apprehension about it?
It depends on the age. So for our younger kiddos, like infants, toddlers, definitely parents are like, let's start OAT. I want to make an intervention. I want to do it early, while I can still really change and modify the immune system.
Sure.
For our older kiddos, we have to get more buy-in. But once they understand how much of an impact it can make on their life, and how it can make going to their friends' houses, going to sleepovers, traveling, eating at restaurants a lot safer, they usually, are open to starting OAT.
So that's the thing, is the kid goes out of the parents' area of supervision because they're going to school, or they're going to a birthday party, or they're going to camp, or whatever the thing is. And there's a certain feeling of not being safe if you potentially are going to have an allergic reaction. So you can, over time, regain that feeling of safety.
And it's easy to control your child's environment when they're with you.
Right.
And so I look at my niece who's 10 years old, and the anaphylactic reactions she's had to wheat have been at school when one of her classmates gave her a cracker that contained wheat, and you're around other children and you want to fit in. And so she's had that bite, and it's unfortunately put her into anaphylaxis. And so just having an option like oral immunotherapy to make, our patients' lives safer is incredible.
Yeah, that's amazing. When should a parent worry that their child is maybe having an allergic reaction? And I've seen, obviously as pediatricians starting new foods, we have parents of toddlers or infants call with questions and concerns. What is it that jumps out at you that is like, that child needs to be seen? This is a situation that we don't want to just wait and see on.
I would say any signs of an immediate type of food allergic reaction. So when we're thinking about immediate type of food allergy, or what we call IgE-mediated food allergy, we're looking for, typically the reaction begins within minutes to within an hour or two.
So you're not going to eat a peanut at 10 a.m. and have a reaction at 4 p.m.?
As long as it's not F-pies, which could
right,
be delayed
right.
vomiting. But
totally
yes.
different. That's the next episode,
Yes.
probably. Yes. But normally when we're talking about an IgE-mediated thing, and this is important for parents to kind of sort out, it's quick. You can usually, if it happens, you can say, what did they just eat 10,
Yes.
15, 20 minutes ago?
It's easy to pinpoint and look back and identify what the allergen was when we're thinking about an immediate type of allergy. But we're often seeing hives, which look like bug bites, mosquito bites, maybe lip swelling, eye swelling, maybe an episode of vomiting, maybe coughing. I would say in our infants, when we're doing early introduction and trying allergens for the first time, the most common reactions we see are on the more mild end. So usually some hives, which respond quickly to cetirizine or Zyrtec, maybe one episode of vomiting. Very rare to have a initial anaphylactic reaction. Have I seen it happen? Yes, but is it on the more rare side? Yes.
And that's why we are now more comfortable and encouraging the early exposure of these allergens, because their immune system isn't going to go crazy the way that it might in an older child.
Yes.
Yeah.
And
so the risk of anaphylaxis is much lower in infants.
yes. And we know multiple studies have now shown, especially after the LEAP trial, of course, in 2015, that early introduction of the major allergens between 4 to 6 months of age is what's proven to have been the most protective as far as reducing the risk of developing a food allergy. So that old guidance of waiting until 1, 2, 3 years of age.
It was 2 or more for me, and I feel still there's this feeling of guilt that I was giving really bad advice for 20 years.
It's at the time everyone was doing the best that they could.
Sure.
And thank goodness, the guidelines have changed and we know what's important as far as reducing the risk of developing a food
So
allergy.
to shift gears a little bit, for parents of young children listening, what is the recommendation? How do we start kids on solid foods? And how is this really completely a 180 from what we used to tell people?
So the current guidance, regardless of risk factors for food allergy, so when we think about risk factors for food allergy, it can be moderate to severe eczema, maybe a family history of food allergy, asthma, eczema, maybe an already known diagnosed egg allergy, regardless of risk factors. So even healthy babies who have no risk factors, you want to introduce the top 9 allergens between 4 to 6 months of age and when your baby's developmentally ready. I sometimes see 6-month-olds in my clinic or 7-month-olds, and the parents are, worried that it's too late. It's never too late. Still, the next day, try peanut, get it in there. And once you've successfully introduced an allergen, you do want to be consistent with it.
Yeah, so it's not just I gave my child a lick of peanut butter once, we're done with that, and we'll talk about it at a year. No, it's early and often.
Early and often, that regular exposure is so important to train your immune system that, hey, this is something that I'm okay with. And we know that immune system is still developing until 5, 6 years of age. So that's where that regular exposure is key.
Yep.
And when we think of the top 9 allergens, we're thinking about peanut, which is actually a legume. So peanut often gets bucketed in the tree nut family.
It's not a nut, it's a legume.
Exactly.
Yes.
And then our tree nuts include like almond, cashew, walnut, hazelnut. And then we have wheat, egg, cow's milk, soy, fish, shellfish, and then sesame was the 9th most common allergen.
So that's the top 9.
Top 9.
Okay. And so you want to expose them between 4 and 6 months consistently. And there's still a bit of hesitation from parents when I tell them about this at the 4-month visit, the idea being by the time I see you again, you should have gone through this. And sometimes I see them back at 6 months and they're like, oh, no, we're still waiting. That really, again, you said it's never too late, but we really, to reiterate this point, we really want them to be exposed early. And that is regardless of, you said, family history, eczema risk, any of those things. Doesn't matter. We want to get them in.
It's the main intervention that there was actually a recent study published out of the Children's Hospital, Pennsylvania, that came out this past fall in the Journal of Pediatrics, where they looked at the impact that early introduction has made on society as a whole. And we saw a 43% reduction in the diagnosis of peanut allergy, 36% reduction of all other major allergens. So
that's huge. It's a big chunk. That's great.
We know early introduction works and we know it's effective.
Yep. Back to what I wanted to put a pin in before. We use the term anaphylaxis. It's a big, long word. How do you define that? What is anaphylaxis? And so what should a parent look for and go, oh, this is anaphylaxis?
Anaphylaxis, quite often when parents and even doctors sometimes in the ER think of it, they think it's only if there's breathing issues involved. Now, anaphylaxis is when 2 or more body systems are involved. And when we think of our different body systems, skin, we could see hives or swelling. Respiratory, we think of coughing, breathing issues, maybe wheezing. And then our GI systems, abdominal pain or vomiting. So hives and coughing or hives and vomiting, that's a sign of a severe reaction. That's where giving epi early is important. Now, say if there's, significant breathing issues involved and only one system technically, because that's such a severe symptom, we would still recommend giving epi.
So kid gets hives and starts coughing. That's anaphylaxis. They don't have to look like they're in huge distress. That's anaphylaxis, and something should be done.
Yes.
I think historically, and still what's happening is parents will reach for Benadryl or call their neighbor and ask for Benadryl and then wait and see. And that is not what we want.
Correct. We know what will treat anaphylaxis quickly and prevent the reaction from worsening is giving epinephrine early. Now, 85 to 90% of cases of anaphylaxis respond to one epinephrine. In those rare 10 to 15% of cases where we have a more severe reaction, we may have to use that second epinephrine.
Yep.
Now,
and it comes in a 2-pack for a reason.
Yes. And
it's not one for school and one for home.
We don't want to split the EpiPens. No. We want to keep the two together just in case you have to use that second one. Now, a lot of, patients and kiddos, even many of my adults, have significant needle phobias. And so Neffy was released in 2024. So what Neffy is,
it's one right there.
We have one right here. So it's a nasal spray. And how it works is you stick it in your nostril, and then as soon as your fingers hit your nose, you push the plunger up. If the reaction isn't getting better after 5 minutes, you use another Neffy. So Neffy also comes in a 2-pack, and you administer the Neffy in that same nostril. Now, Neffy is approved for 33 pounds and up. There used to be an age requirement, which they got rid of. And so this has been amazing. It's so compact, so easy to carry. It's less, labile to high heat.
Yeah, it's more temperature stable, so you can leave it in your car.
Yeah. Up to like 122.
Yeah, you don't want to leave it in you don't want to bake it.
Yeah.
But the concern about epinephrine injectors was that it was much more temperature sensitive, and you really didn't want to leave it in a hot car at all, or you had to really protect it. This is more. It has a longer shelf life, does it not?
Longer shelf life.
So it's not a needle. It's more temperature stable, and it lasts longer. Really, no downside, and the effectiveness is equal.
Yes, I use it in my clinics for severe reactions, and it's been very effective.
Used to be, the teaching was, I used to tell people, EpiPen equals 911. If you use an EpiPen, you should be calling 911 right after. And that's no longer the case. Is that correct?
Correct. So we saw during the COVID-19 pandemic, when the guidance was, of course, to avoid the emergency room, that many cases of anaphylaxis that occurred at home resolved with one epi, and those many patients did not need a second epi to be administered or did not need to seek medical care. Now, currently, we say if the reaction's improving quickly with one epinephrine, you're with your child, you're in a safe environment, you have access to that second EpiPen, you've support around, so another parent or caregiver is around, there's no significant respiratory distress involved, you can, continue to monitor closely at home. Of course, if there's, significant respiratory distress, definitely, we would recommend going to the ER to have the lungs listened to. And
if the child just doesn't look right.
Yeah.
After the first
and
dose.
Parents know, so we always say, like, if your gut feeling is still, I'm worried, when in doubt, it's always okay to take them in, but you don't always need to do that.
No one's going to ever fault you for going to the ER or calling 911 if you've done epinephrine. But I guess the idea is that we're trying to, there's a certain amount of hesitancy, like, I don't want to go to the emergency room. My mother famously said, I'm not in the mood to go to the emergency room, which I think most parents are probably not in that mood. They're trying to decrease the disincentive about giving epi by saying, hey, if you give the epi and your child is doing well and improving with that and you're observing them, that's okay.
Exactly. If things are getting better rapidly. And so that's where even our oral food challenges, which we do in clinics, so those are sort of food trials that we do over 3 to 4 hours if we feel a patient isn't allergic anymore or may have outgrown their allergy. Often if we need to give epinephrine for anaphylaxis, the parents are in awe of how quickly it works. And so just from seeing, how quickly their child got better, there's some buy-in of, hey, if I use this quickly and I use this early, that's what's really going to make an impact.
And what I've taught families in the past is the only harm you can do with epi is not using it.
Yeah. I like that. Yeah.
I mean, if you're a little over aggressive with it, it'll make your heart rate go fast for 10 minutes, but you're not going to harm anyone who doesn't have like old and has severe heart disease or something. But for a kid, and we're talking about pediatrics here, there's really you can cause no harm with epinephrine. The only harm is to not give it in time. Exactly.
And I always say if you're debating whether or not to give it, err on the side of caution and give it.
Yeah, or if you've got it in your hand, you should probably administer it.
Yeah.
Okay. So we talked about guidelines for newborns and infants starting. Risk factors for food allergies, are there certain, family history is a role. Something I want to ask about is, it's interesting, in my family, I have 3 brothers and a sister, and I think we have the total of 14 kids amongst us. And of those 14 kids, I think 4 of them have significant food allergies. And every single one that has food allergies was born via cesarean section. And I don't think any of the kids born vaginally have any food allergies. Mm-hmm. So I know there's an association. Is there any more insight in the last several years about that risk factor and what, if anything, can be done to mitigate that?
That's a great question. So we know allergic conditions in general are increasing. So not only food allergies, but environmental allergies, asthma, eczema. When we talk about cesarean sections versus natural vaginal deliveries, we're thinking about the gut microbiome. Mm-hmm. And so we know C-sections, antibiotic exposure. We know that now that we're living in cleaner, more sanitized environments, our immune systems aren't exposed to bacteria and parasites or the bad bacteria. So, we're training our immune system to respond appropriately. So what's happening is, because our immune system isn't responding to other types of pathogens, when a food allergy protein comes along, it triggers an allergic response because the immune system treats that food protein as a threat. And that's what sort of initiates mast cell reactivity, histamine release, which causes the range of symptoms that we see in allergic reactions, from hives to anaphylaxis. So I mentioned gut microbiome, and I actually had a patient ask me this yesterday. So there's a lot of research that's been done as far as are probiotics helpful at all when we're thinking about food allergies, eczema, asthma. The evidence has been very mixed. But what I told this family is, it won't cause any harm.
So there's no downside to it.
There's no downside to starting but is it, if you're on probiotics, will it eliminate food allergies? Will it prevent, future food allergies from developing? Not necessarily. Right now, again, that main intervention that is effective is that early introduction and then consistent exposure of the top 9 allergens.
Got it. Okay. And as kids go through back to the oral immunotherapy and they graduate, what can they expect? If they're in this program and getting immunotherapy, are they at risk for developing other food allergies along the way? Does that happen where they're getting their peanut allergy treated and now a new one pops up? Or once you're kind of tamping it down, do we seem like we've gotten control of the allergens?
So sometimes you could be doing everything right. You try the top 9 allergens, you're giving them regularly to your child, and they can still, sometimes develop an allergy. Now that is on the more rare end. The data still, of course, is we don't want that to skew anyone from not introducing the allergens early, but can we see allergies pop up later in life? Yes. So we know 15% of food allergies are diagnosed in adults. So many adults, more than half of their allergies, at least one was diagnosed during adulthood.
And do you think that they were diagnosed later, or do you think that it developed as an adult?
A mix of both. So our adults, of course, the common stories, they had this remote history of they were at a restaurant and they ate some shrimp and had some hives like 10 to 20 years ago. And from there, they're like, I'm just going to avoid all shellfish. And then they come to their allergist or me 10 to 20 years later, and we skin test them and find out it's only shrimp that they need to avoid. Everything else is fine. So often it is delayed diagnosis or maybe even delayed introduction of trying that allergen. So it could have been that they had a shrimp allergy all along, but weren't exposed until they were on vacation on the beach and had
and
it
then
then.
they ate it and then they had a reaction. So it could be both. It could be dormant or not undiagnosed, but they avoided it because they didn't feel well, or it can just be triggered as an adult.
Yeah. And then with our adults, we often see, of course, they have environmental allergies and hay fever. And so there's a condition called oral allergy syndrome.
Oh, let's get into that. I love that.
Where some of the proteins that we see in raw fruits, vegetables, and even some nuts are the same proteins that are in some pollens. And so the immune system doesn't know how to recognize one as the pollen versus one as the food. So for example, when we think of birch tree pollen, it's, commonly associated with oral allergy syndrome, which is when we see an itchy mouth, itchy throat, maybe itchy lips with eating raw apple. But then if you have that processed, cooked apple pie, you're just fine. And so we know in most cases of oral allergy syndrome, if you're heating the food, you're more tolerant to it.
It changes the protein shape. So
yes,
that's kind of where we start sometimes. I love looking this up when someone comes in and says, oh, I eat bananas and my mouth gets all tingly and itchy. And then you can look up oral allergy syndrome, and there's like a chart of which pollens are associated.
I love that
with
chart.
It's fascinating to me. What's associated with birch? Do you know off the top of your head? I don't want to put you on the spot.
Yeah, banana, a lot of stone fruits. So cherries, peaches, apples. The main nuts that are involved are almond, peanut, hazelnut. Now, you're often not sensitized to every raw fruit, vegetable in that family, but some of them. And so what I saw as a general allergist that actually can help oral allergy syndrome is sometimes doing allergy shots. So treating the environmental allergies and treating.
So decreasing your allergic reaction to the birch pollen is then going to decrease the symptoms you get when you eat those stone fruits or.
I have had, some patients in the past who notice the benefit.
Is someone with oral allergy syndrome at risk for anaphylaxing to that food?
We can 10% chance of seeing that with the nuts. So I actually did see that during
nuts are scary.
Nuts are scary.
So if you eat apples and you get an itchy mouth, most people who just don't eat apples. But if you did for some reason, is that like an apple allergy? Is that going to become an anaphylaxis thing? Because I don't know anybody.
Rare.
I don't know anyone with an allergy to apples.
Yeah, extremely rare. And sometimes it's one of those things where we know tree pollen season is often like end of February through May, June, and so it's sometimes during those months when the tree pollen's blooming that they may experience those oral allergy syndromes with, say, apple. But if they ate it in December, they may be totally fine.
With the ebb and flow of pollens with environmental allergies, does your IgE level in your blood vary? Like if you tested someone's IgE level to birch, is it vary when birch is in the air versus when it's not, or is it more stable than that?
I have seen when environmental allergies are uncontrolled or during, peak pollen season, your total allergy antibody level and pollen blood testing can be higher.
Okay. Interesting. Yeah. So there can be some variation. You could eat apples in the winter and be fine, and then spring.
With some patients, in Washington especially, California is harder because, it's nice here year round. But
Is this the allergy capital of the world? I've been told that the corridor between like Martinez and Fremont has the highest density of pollen in the air because of the geography.
I feel like everywhere I've lived, and I've lived in a lot of cities in the U.S., everyone thinks that the city that they live in has the worst pollen.
I think that's a phenomenon. The other thing that I definitely see, and every spring around this time when the weatherman starts talking about pollen counts, they always say it's going to be the worst allergy season we've had in years. Every year. I've never been watching TV and said, oh, allergies not so bad this year. Have you ever heard that? I've never heard that because people are just miserable with it.
I've never heard that.
Yeah,
and
never had a mild allergy season.
I actually said this to a patient today. It's a really bad season. And then in my mind, I was like, I say that every year.
They're all, literally every year. It's bad this year. And I'm sure that there's some people who maybe it isn't as bad for, but those aren't the ones who come into the office and you're seeing the ones who are really uncomfortable. So for them, it's the worst one ever.
Yeah.
So back to OIT. What's the normal time frame for, say, a toddler starting on that and getting to a point where, not that they can eat the PBJ, but that they are safe if they were to accidentally eat a cookie that had a nut in it?
So on average, it takes about 8 months to reach their maintenance dose.
So not that long.
Not that long. And peanut, tree nuts, and the seeds like sesame, sunflower are usually 6 to 8 months. Wheat, egg, and milk are a little bit longer, towards that 8 to 10 month time frame.
And how often do they need to come in here for their dosing and monitoring versus doing it at home?
So the earliest that we do an updose or an appointment where we increase the allergen dose is after 2 weeks. I always tell my parents that if, their work schedules are off, if they're traveling, if you have to push it out to every 3-4 weeks, that's totally fine. But the earliest that we do the increase is after.
So you can do it more slowly.
Yes.
If you stay the same dose and then you titrate upward more slowly, that's not going to affect it. It's just going to take longer.
Exactly.
But it's not going to harm the process.
It won't harm the process at all, because we don't want this to be disruptive to your life. And so things come up in life. You can't, predict some things. And so if you have to push it out a week, that's totally okay.
Okay. And then they do it every day at home?
It's daily dosing, yes.
And does that continue forever, or is there a certain point at which they can then make it weekly or every other week?
The current evidence and data has shown that daily dosing for at least 2 years has made the most benefit from an immune system protection standpoint. And then from there, if we're seeing the testing to decline, which we do, and we're not seeing reactions, we can go down on the frequency to a couple times a week.
And is there a contraindication? Is anyone excluded because of whether it's severity of their allergy or other reasons that they can't do it?
I've never excluded anyone because of severity of allergy or extremely high blood testing. I'm extremely grateful that a medicine called Xolair was approved in 2024 specifically for the treatment of food allergies. And so, as you know, it's a medicine that's been around for more than 20 years.
So tell us about that.
So Xolair, it's a biologic medication that works on the allergy antibodies, your IgE antibody, to essentially make your allergy cells less reactive. So if you have exposure to peanut and you're on Xolair, you hopefully have no reaction at all. And if you do, it's more mild. And Xolair also increases your reaction threshold. So the amount of peanut that you can eat until you have a reaction. And so sometimes in my more severe patients where we're treating several allergens at one time, we may do Xolair beforehand for a couple months and then overlap with Xolair and oral immunotherapy.
So you can be on Xolair and do oral immunotherapy simultaneously, or do you usually try to wean off the Xolair after you've started?
We'll usually wean Xolair off after a couple of months after patients have shown that they've been doing well on it.
But it doesn't interfere with the OIT working like initially. It doesn't counteract what you're trying to accomplish.
No, in fact, it actually, in our more severely allergic kiddos where we're treating multiple allergens, it makes the process a lot smoother.
And how is Xolair dosed? How is it administered?
So Xolair, it's given subcutaneously.
It's an injection.
Yes, it's an injection. It's given either once a month or twice a month. And how the dose and dosing frequency are determined is by the total IgE, so total allergy antibody level, as well as body weight. The first 3 injections are given in clinic with a 2-hour observation. That's because there's a black box warning that Xolair can cause anaphylaxis. That's because of an inactive ingredient in the Xolair. I've never seen that happen.
Okay. But that's there. So you just cautiously watch them for 2 hours.
Yes.
Yep.
And then after the first 3 injections that are given in clinic, subsequent injections, if patients feel comfortable, can be given at home. So it's been an amazing option for our adult population where doing oral immunotherapy is more tough with their work schedules. One of the questions you asked before I went off on a tangent is, what are risk factors for OIT or could make someone potentially not a candidate? Uncontrolled asthma, and then, as I mentioned, like uncontrolled eosinophilic esophagitis. So we would, of course, want that to be controlled. Both of those diagnoses to be controlled before we start OIT.
And will the Xolair decrease those?
Xolair, so it was initially approved for treatment of asthma. So if you have asthma and food allergies, you get a 2-for-1. If you have chronic hives, asthma, and food allergy, you get a 3-for-1. With EOE, the biologic that's approved for EOE is Dupixent. So it's different, but with EOE, we would work closely with the gastroenterologist.
And they might get put on Dupixent, and that's not a contraindication for starting the oral immunotherapy.
No, not at all.
So once you get those symptoms under control, whether it's with Xolair or through the Dupixent, then they can start.
Yes, Dupixent or like swallowed steroids or a PPI.
Yep.
Yeah.
During my tour, I saw a whole closet full of toys. So what happens with kids? When do they play with the toys? How does that work?
Oh my gosh. The toys are...
Because they're like famous. That's the reputation of the toys here.
Our patients never want to leave. So we have, when I think about the San Francisco office, you know, the popular toys are the garbage truck. It's always, where's the garbage truck? Where's the ice cream toy? Mm-hmm. We are very well known for our toys. And I would say we're the one pediatric clinic where the kids come and they don't want to leave. And it's often their favorite place. Our staff is wonderful. They'll remember, you know, what toy each patient loves, and they'll have it set up in the room before the patient enters the room. So it's an amazing, we want it to feel, you know, we don't want it to feel like a doctor's office when you're here.
Yeah. So they get their immunotherapy, and then they have to wait for a certain amount of time?
Yes.
And that's when the toys come in?
That's when the toys come in.
Okay.
So typically when we're talking about an updose or increased appointment, the nurse will come in, grab vitals, then the provider, doctor will come in, make sure everything's been going well the last couple of weeks. We'll get our patient dose, and usually it's a 1 hour wait period. And during that time, they're playing with their toys or drinking some juice, they're eating some snacks and having the time of their life.
It's a good time here at Latitude. That's great. And getting their allergies taken care of at the same time.
Yes.
So wonderful. Any other topics that I haven't kind of touched on that you think I have glossed over or missed based on what you do here at Latitude?
I just hope that patients know that there's a path forward beyond just avoiding what they're allergic to.
Well, I think that what you do here is unique compared to what I think most allergists do. I'm not saying that other allergists don't do OIT, but this is really what you focus on. This is your wheelhouse.
And access to care is so important. So there was a recent report that was released by the FAIR organization. That's the Food Allergy Research Education Organization, the largest nonprofit for food allergy research and advocacy in the U.S. And they found that 81.5% of U.S. counties don't have an allergist. And so we're so lucky just being in the Bay Area or Southern California, New York.
81% of counties in this country, there's no allergist available.
There's no allergist available. And so, you know, we're the largest network of food allergy clinics in the U.S. And so I encourage anyone that's, you know, listening, even if you're not in the state of California or New York, to look us up at latitudefoodallergycare.com. If you're, you know, have had a food allergic reaction and don't have access to an allergist, talk to your primary care doctor, at least get an epinephrine prescription. There's some telehealth allergy practices that you can at least start with, and then until you get connected with an in-person allergist.
So they do have that. There's telehealth allergy.
There is some telehealth allergy, but...
Okay. Obviously, there's limits to what you can do, but they could at least help you manage the world of food allergies and get an epinephrine prescription to have so you're safe.
Yes. Yeah.
Well, that's wonderful. Thank you so much for spending time with me. This has been again, every time I do this, I come in with questions. I leave with more. I learn so much. So a lot of it's obviously educating the public who are watching, but also just educating me because my knowledge base just keeps on increasing, which is great.
Thank you so much for having me this
I appreciate
afternoon.
your time so much. And
thank you so much again for having me, Dr.
Thanks
Nash.
so much.
It's a pleasure.
Take care. Have a wonderful day.
Thank you.
All right. And that's our show for today. I hope you enjoyed the discussion regarding food allergies, how they're diagnosed, and how they're treated. It is amazing how with oral immunotherapy, people with significant food allergies can get to the point where at the very least exposure won't result in a trip to the ER, and sometimes can even mean being able to eat those foods as part of an individual's diet. I would really like to thank Dr. Dhami for taking the time to sit down and meet with me to discuss what they do at Latitude. As always, I learned so much and left with a much greater understanding of what can be achieved with oral immunotherapy, or OIT. Until next time, this is your host, Drew Nash, wishing you a peaceful, healthy existence full of laughter, children, and delicious food. The opinions and beliefs expressed on the owner's manual are that of myself, Dr. Nash, and my guests, and do not necessarily represent those of sponsors or other governing boards. The owner's manual is recorded and produced at Neutron Sound, Danville, California. The content of the owner's manual is the intellectual property of Andrew L. Nash, MD, and One-to-One Pediatrics Incorporated. Copyright 2026, all rights reserved.